Hello, I'm Don Pelto. Welcome to the $1 Million Minute. I'm going to go over the things that help me get to the $1 Million mark and beyond in my private practice in podiatry, and that's what I do here with Podiatry Practice Mastery. Okay, I was having a person called me the other day, and they said, Don, he said, Don, I had a patient come in, and they wanted one toenail to be treated for laser, and I charged them $85. And he's asking me, is that appropriate? Is that too much? Is that too little? And then we got talking about, and he was asking me about my protocols for softwave for neuromas. So with this conversation we had, the first thing pointed out to me, I usually talk more patients out of laser than into laser. But if you really believe laser works on toenails, you should be able to sell packages. So the only way I do nails is I do packages of 6. So I do 4 weekly sessions, and then I do a 4-week follow-up with another one, and then a 4-week follow-up with another one. And so those 6 treatments, I only have the one that's not doctor done, so it's the lunula, only because it doesn't take my time. There are a few patients that want to do that, but I don't do just like an isolated toenail. They pay, it's $125 per foot, or $250 for both feet, and then they would also get my fungal package. So they would also, this is the package that I always talk about. They're going to get a UV light, shoe spray, and the biotin. So one of the things I find that it's hard for doctors, especially this guy. He said to me, "Oh, Don," and they never get the UV light. They always get the spray. Well, I say it's how you present it. It's you give them an option. So the way I tend to do it, you have to anchor the price to something else. So what I do when I use my fungal nail treatment sheet. So if you want this fungal nail treatment sheet, shoot me an email, don@podiatrypracticemastery.com. I'll happy to send it out to you. On there, you'll see it's a list of things how I treat it. Usually it's terbinafine, but then on the bottom of the sheet it says laser. And the reason I do that more is as an anchor than anything else. So what anchoring means is I'm going to go through, I'm saying you're going to get your LFTs, you're going to get your terbinafine, you're going to do this biotin. Most of my patients, I don't have them do laser. If you wanted to do it, it would be $2,000, or it's about like that. That's the amount for that amount of sessions. And so when I say that $2,000, they're like, wow, that's a lot. And then I go through it, and to prevent recurrence, we do UV light once a month, and then the shoe spray once a week. So I think it's important you tell patients how to use the things as well. So UV light once a month, shoe spray once a week, and then biotin once a day for the first 4 months. When they do it that way, with that explanation, I've anchored them at the 2,000 mark, and then I say, and all these things, the biotin, everything else, it's about $200. So it's like 10% of that 2,000 number I just told them. So that's how I do it with that. Now, if a patient does want laser, they'll get the laser and they'll get the kit. So it's like the total for all that is around that much. So that's just kind of one explanation. The other explanation that this doctor was asking me was about softwave, and he said, "Oh, and you guys switched to softwave?" And I said, "Well, we didn't really switch. We bought a second focused or non-radial machine." And that was the softwave because we needed a second machine. I kind of like having both. I have one focused with the Storts, and I have one they call it unfocused, but they're both, we call them non-radial in the office. But it's nice to have both to see how they both work. They're both working very similarly at this point, but there are pros and cons to kind of each of them. Okay, but I just want to kind of rationalize or kind of explain that. So I think whenever you're trying to do things, you want to develop kind of a system of how you explain it to patients, and this is good for the doctor, but it's also good for the staff. And I realized kind of a point that it was kind of my error. Like, I'm assuming everyone's getting these Amerigel kits, and I'm finding everyone's going out without the Amerigel kits. So a lot of times the staff they don't know how to explain it the right way. They're saying, oh, you could do this, but it's like this amount, or you can just soak, and it's the same thing. And really it's not. It's because they haven't been taught how to do it correctly. So what I did is I took the staff in and I kind of explained to them how to explain it better. So certain things I think they're kind of training problems. So and then the disconnect is when we offer it, then they don't do it. So I think packages is one, and then kind of explaining. Okay, let's go into the day here. So this is a recording on a Thursday of my patients. So it was a full day. So first patient was came in, 73-year-old female. So she did an office visit, posterior tibial tendon dysfunction. She was casted by my staff for I think it was a medial blaze AFO brace, and then she also got orthotics. She got orthotics as well as the brace. Basically, I explained to her the brace would be used for unstable surfaces, a lot of standing and walking, but the orthotics would be used every day. Next was a 77-year-old female for Q10s number 1. So we put this on her. Next was a 45-year-old male for EPAT number 2. And he is here for heel pain, and I just reminded him that at the third visit we'll be scanning him for orthotics. So I usually do 6 sessions of shockwave. At the third session is usually where I scan patients for orthotics because their pain is coming down a little bit. And next patient was a 57-year-old female with peroneal tendon pain, office visit, x-rays, and then she also had a matrix on the right foot. So this is another thing. So always asking patients, like, what else do you have? So she came in for the peroneal pain. She said, by the way, I had this ingrown toenail that's been bothering me and has been bothering me chronically, so that's why we did the matrix there. The peroneal pain, I explained if it's not going to get better with the icing, anti-inflammatories, things like that, then we'll either put her in a boot, do a cortisone, or do shockwave. Next, there's some post-ops. This was a post-op bunionectomy, hammer toe 2 and 3. So I did x-rays for him. I'll go through all those. The next x-ray, the next one was a status post hardware removal from a bunion, and then there was another one which was a status post derotational 5th digit toe. That she was walking on the side of her toe, and she's doing fine with that. So those, and then there's one more that was a status post amputation, digits 2 and 3, and unfortunately she has some hammer toes on 4 and 5, and she's starting to ulcerate on the 4th, so I was talking to her possibly about either straightening that or just amputating the 4th and the 5th. So that's kind of a struggle, because she already has an amputation, partial amputation to the 1st, so it's kind of going down the line. That's a struggle, that one. Okay, let's go back into the day here. 56-year-old female, she was here for a fracture on the 5th met shaft. So she was treated fracture code, and she also had a porokeratoma, so I did lesion destruction for that, or a IPK, whatever you guys want to call it. Next patient was a 69-year-old female, shockwave number 2 out of 4 for a fibular fracture. So once again, transverse fibular fracture, doing radial for the soft tissue to get the ecchymosis and edema down, and doing the focused or non-radial on the area of the fracture site to get it to heal a little bit better. She's in a cam boot. Next was a matrixectomy for an 18-year-old girl. Next was a follow-up from a fracture. She's doing better. And there was a couple of nail patients that jumped onto my schedule only because my partner was in surgery, and so the nail tech was there, so I had to oversee her patient care. So I did a couple of those nail care patients. Next patient was a patient that had some plantar fascial pain and also some sinus tarsi pain. About a year ago, I did injections due to arthritis to the sinus tarsi, so I did that, and then I also did the plantar fascial injection for him. That was the morning. Afternoon was a 64-year-old female, 6 weeks after shockwave, about 50% better, and then I'm going to see her back in another 6 weeks. So I think a lot of it is after shockwave, the 6-week follow-up, like I don't expect 100%. I expect maybe 50%. And so as long as they're improving, then I just push them down the road, and then the shockwave will continue to work. Sometimes I'll do a touch-up session, and I tell them that, but a lot of times I do not. And if it really, really hurts, then I'll transition to like a cortisone injection. But I think a lot of the trick with shockwave is the 6-week follow-up, like measuring the success of the procedure with the patient and kind of being clear about that. Next was a patient, 78-year-old female, that came in for a diabetic foot exam. Next was just a kind of an older patient that came in. I think this was for nail care or something like that. Sorry, I can't read my notes here. Next was, there's one more surgery, status post arthroplasty, 5th digits bilaterally. She's super happy. No follow-up because she's doing so well. Next was a 64-year-old female, number 4 out of 6 for peroneal tendon pain. But she also had a 5th toe maceration that got cellulitis or a little infected. So we did x-rays to verify that was the case, and put her on an antibiotic, and we did that shockwave as well. So she had a maceration between the 4th and 5th toe. She has got like talar bunion, pushes over her toe, hurts, got macerated, did lamb's wool, debrided out the area between there, and did betadine for her. Next was the first MPJ, patient with pain, first MPJ. She's a chronic nail patient, usually not chronic. She comes back all the time for nail care, but she was here for something else. I did an injection to the first MPJ with ultrasound guidance for her. And then another patient that came in, 68-year-old female for neuroma symptoms, kind of did education stuff on neuromas, not really hurting her right now. And then finally, last patient was a diabetic neuropathic that had a fourth met base fracture. So got x-rays. Last time she came in, 4 weeks ago, my x-ray was not working, and I don't exactly know what happened, but I got the x-rays. I could see the fracture there. I talked to her, if it doesn't heal, because that's kind of a hard place to heal sometimes, we may do some non-radial shockwave on that area, and but I'm going to see her back in 4 weeks. She is a teacher. She'll be done with school soon, and we did... I did not do fracture code last time, and I didn't do it this time. So this is one of the rare cases. I didn't do the fracture code just because I couldn't definitely see it on the x-ray last time, and it was kind of awkward. I didn't know if I should do it a month afterward, so I just didn't do it. I just billed those 2 office visits and then the x-rays for this patient. And so she's going to come back in 4 weeks and keep in the boot for a little bit longer. Okay, that was the day. So once again, if you guys want my treatment sheet, just shoot me an email down at podiatrypracticemastery.com. Happy to share that with you. Okay, have a great day.